Hi everyone, my name is Jessica Collinsworth and this is my presentation on pediatric asthma for patients between the ages of 5 and 11. First, I will begin with an overview of the signs and symptoms of asthma in this age group. It is interesting to note that 80% of pediatric asthma patients exhibit symptoms before age 5, but they can often be misdiagnosed. Coughing and wheezing are the most common symptoms, but some children may experience shortness of breath, chest discomfort, or nasal polyps may be discovered upon exam. It is important to note that if an asthma patient is doing poorly in school and is tired during the day, this may mean that their asthma symptoms are keeping them awake at night. The cough that is associated with asthma is usually a dry, hacking cough, but can sometimes produce a clear, thin, white sputum. The cough will last for longer than 3 weeks, occurring at night, reoccurring seasonally, and may be brought on by cold air, laughing, crying, or exercise. It is important to note that sometimes cough with these characteristics is the only asthma symptom present in children. Wheezing is another common symptom for pediatric asthma. It is usually heard upon exhalation, but inspiratory and expiratory wheezing is an indicator that the asthma is severe. If little or no lung sounds are heard upon exam, this could mean that the child is not ventilating properly and may be a medical emergency. Precipitating factors that can exacerbate pediatric asthma include upper respiratory illnesses, exercise, weather, tobacco smoke, stress, allergies like dust, insects, rodents, pets, pollens, and molds, irritants such as smoke from fires, cleaning products, perfumes, hairspray, paint, etc. It is important to discuss and educate on possible triggers for asthma attacks with the patient and their caretaker. Allergy testing may also be warranted. The diagnosis of asthma is somewhat dependent upon the age of the patient, as very young children cannot comply for spirometry testing. Spirometry is appropriate for most children between the ages of 5 and 11 and is the gold standard for diagnosing asthma. The diagnosis for asthma may be made if the forced expiratory volume increases by 200 mL and is greater than or equal to 12% higher than the first reading after a short-acting beta antagonist is given. It should be noted that a chest X-ray is not necessary unless the patient does not respond to initial treatment. After the diagnosis of asthma is made, it is important to further classify the severity of the asthma as either intermittent, mild, moderate, or severe. A patient that has symptoms less than 2 days of the week, is awoken less than 2 times per month, and only needs to use a SABA inhaler twice per week, is able to perform normal activities and has a normal FEV between exacerbations is considered to have intermittent asthma. A patient with mild asthma will have asthma symptoms and need a rescue inhaler more than 2 times but less than 7 days out of the week. They will wake up about 3 to 4 times per month because of asthma. They will have minor limitations in their daily activities. A patient with moderate asthma will have daily asthma symptoms and need a rescue inhaler daily. They will be awoken more than once a week, and they will have some limitations in their daily activities. A patient with severe asthma will have asthma symptoms and need a rescue inhaler multiple times throughout the day and night. They will have extreme limitations in their daily activities due to asthma symptoms, and their FEVs will be less than 60% of what they should be. Next, we will discuss the management and treatment of asthma. The goals of treatment are to prevent asthma symptoms from occurring, maintenance of normal pulmonary function, only needing a rescue inhaler less than twice a week, to have the patient be able to partake in all of their daily activities without limitation, prevent severe asthma attacks in hospital visits and stays, and lastly, to have minimal or no side effects from the medications that are used to treat asthma. The pharmacological treatment of asthma is done in a stepwise approach depending on the severity of asthma and the initial response to the medication. Intermittent asthma may be treated with a PRN short-acting beta antagonist, such as albuterol, also known as Ventolin, Proventil, or ProAir. For mild to moderate asthma, a low-dose inhaled steroid such as Qvar, fluticasone, budesonide, or mometasone is necessary. For moderate to severe asthma, the addition of a long-acting beta antagonist such as salmeterol will be necessary. The guidelines state that if a patient is not being managed on a PRN-SABA, medium-dose inhaled corticosteroids, and a LABA inhaler, a referral to an asthma specialist is warranted. Inhaler spacers should be used, and the patient should be instructed to rinse or clean their mouth out after every use of a steroid inhaler. Asthma action plans can be an effective tool in preventing asthma exacerbations. They are also a way for healthcare providers to clearly communicate with the patient and caretaker which asthma medications should be taken and when. It also provides the provider's contact information, outlines signs and symptoms of worsening condition, and what to do should the patient's condition worsen. An asthma action plan should be a part of every pediatric asthma patient's care plan. The guideline used for this presentation is from the National Asthma Education and Prevention Program. Information was also obtained from UpToDate. The links for these pages are provided below the video.